John Starr. I'm an orthopedic spinal surgeon at Washington Orthopedics and Sports Medicine here in Washington, D.C. We cover most of the Washington metro area. I do predominantly spinal surgery. I do a fair amount of revision type work, reconstruction, tumor and trauma. They finally come to surgery. The main diagnoses for which surgery is performed are disc herniations and spinal stenosis. These two diagnoses tend to have something of an age bias as well. The pure disc herniation tends to be a 40s and younger age group, and the degenerative stenosis, and I'm sure the term perhaps gives that away a little bit, it tends to be an older population, the 50s and beyond. The decision to go forward with surgery on the cervical spine in particular is predicated on symptoms, their duration, their severity, and importantly, above all, is your physical findings. Weakness is a problem, and that is what gets my attention more, frankly, than your pain. As they say, I can tolerate your pain a long time, but weakness, no. It's my job to stop the trail of conservative management at that point. So if one has some weakness that has persisted, pain that is no longer responsive adequately to the conventional methods of medicine and therapy, then you may well be at the point of deciding upon a cervical spinal surgical procedure. But let's take a cervical disc, a disc in the neck. Because this area of the spine is where your spinal cord lives, most of this disc surgery is done through the front, in fact, because the work has to be done before getting to the cord. We can't manipulate the spinal cord, so we do the work in the front. It actually is an operation that's been done almost unchanged for about 60 years. There are certain patients who might think, well, I want something new and modern. But in fact, I think it speaks to the elegance of the anatomy and the procedure that we slip in through the front of the neck, and we separate tissues with very little trauma, extract the disc, and either replace that space now with a bone graft refusion, or more recently, in the last few years, we've been using a lot of what are called total disc arthroplasties. Now, arthroplasty just means to change the joint. So the outcome from the standard cervical discectomy, and actually the outcomes are relatively the same whether one employs the fusion and the small plate or actually the disc arthroplasty, the implant, they're excellent. Now the excellence of one's outcome depends in large measure upon the decision making that goes into the surgery. Do they have the exact diagnosis presented? Do they have certain physical findings and a distribution of pain consistent with the problem? And then, if everything lines up and the operation is done properly, these folks are among the happiest surgical patients across any specialty. It is a high success rate. It is a return to normal function, and in most cases, normal sensibility and an unfettered lifestyle.